Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. So, welcome to another Vivacast episode. We have Martin here from the delightful Nordic countries, whose English is impeccable. We're covering pregnancy today, and remember, pregnancy is a big part of the primary FRCA exam. The subjects that you should be able to talk about that spring immediately to my mind for this exam is the physiological changes of pregnancy, featured today, management of major obstetric hemorrhage, coming later, but also inserting an epidural, troubleshooting an epidural, deciding between epidural top-up, spinal, and general anaesthesia for caesarean section, the pathophysiology and implications of preeclampsia. You should certainly be able to talk through the mechanisms of action of those drugs used in major hemorrhage. You should be able to touch on amniotic fluid emboli, and bear in mind that your anatomy conversation questions in the OSCE might be talking about the layers you go through to access the intrathecal space and the epidural space. Anyway, let's get on with giving our happy-go-lucky Martin a good crack at some Viva questions for the EDAIC. So, do you fancy some physiology?
Yes, please.
Yeah, exciting stuff. So, let me just make sure I've got a point of reference. Can you describe to me the physiological changes associated with pregnancy?
Yes, so the physiological changes associated with pregnancy I'll break them down according to organ system. For the central nervous system, there is not much actually. For the respiratory system, you get a higher respiratory rate, whereas the tidal volume drops a bit, and this is from the third trimester and onwards, and the functional residual capacity goes down, and this is due to the diaphragm being displaced cranially. You get a slight metabolic alkalosis due to the hyperventilation, and for the airway, you do get swollen airways, so you can expect difficult intubation situation. For the cardiovascular system, you increase your cardiac output by almost 50%. You increase your heart rate, increase your stroke volume, and this is to accommodate the placental transfer of blood. I believe the quoted amount of cardiac output that goes straight to the placenta is close to 25%.
Yes, it is 25% or so.
But I always take those numbers with a pinch of salt, because if you add them all up together for every organ system, it equates to way above 100. I find that hilarious. But anyways, hematological changes do occur. There's a prothrombotic state, though the platelets can be lower due to them being used up. The prothrombotic state is thought as functional due to the impeding risk of bleeding during giving birth. The hematocrit, I think the hematocrit is slightly lower. There's a functional anemia due to the plasma volume being expanded with not erythrocytes, but everything else within the blood. For the liver, I believe the liver enzymes should be normal, but there are pathological states associated with pregnancy that would affect the liver. That was
And then just to touch on the GI system and the renal system.
For the GI system, I believe that the sphincter tones of the lower and upper esophageal sphincters are lower. There's a high risk of regurgitation and the gastric contents going the wrong way, so to speak. For the renal system, due to renal blood flow being tightly auto-regulated, I do not think there's a increased GFR, but renal blood flow is the same.
And what happens to the plasma creatinine level?
That ought to be slightly lower.
I'm trying to take it to be a bit more clinical. What would be your approach to stratifying cardiac risk in pregnancy? And particularly, what disease processes does the World Health Organization recommend against pregnancy, and why?
So for cardiac risk during pregnancy, the situation where the risk is highest is at birth, like at the stage of vaginal delivery, which puts a stress on it puts higher demands on the cardiovascular system. The birthing mother needs to handle a big venous return to the heart once the placenta is abolished, but it also needs to accommodate the massive sympathetic surge that goes along with delivering the fetus. So any cardiac disease that limits output, be it arrhythmogenic or be it structural, would pose concern. I believe there are certain states where the WHO recommends against pregnancy, and those I think are arrhythmogenic states such as the arrhythmogenic right heart disease, I think, and not corrected structural diseases like a congenital defect that would make it possible for you to have pathological shunting of blood, such as I'm thinking about an Eisenmenger syndrome. I think that's one of those.
Definitely.
And I think, I'm not sure I'm going to say a univentricular heart with a right, like a functional systemic right side. But I think the left side ones do get a green light for delivery, but I'm not sure.
Yeah, it's probably a good opportunity just to dip out and discuss it, because it is this is quite a niche question by any stretch of the imagination. And the approach to stratifying it would be to say, well, what's the defect? Is it valvular? Is it structural, like endocardial cushion problems, ASD, VSD? You touched on univentricular or LV hypoplastic syndromes. Or is it, another important one is pulmonary artery hypertension. And then you would say,
you sort of get lost because it's not primarily cardiac.
Yeah, but it comes under that because of the right ventricular failure, I suppose, that comes with it. And then you could approach it with, well, is it a patent ductus arteriosus and it's not really causing any bother? Well, crack on. Versus, is it an uncorrected congenital heart defect? You would be cautious about approaching that. Or have they got any disease process that leads to a severe valvular abnormality or a heart failure state? Anyone with heart failure is at higher risk. You could then quantify that with echocardiography and monitor them throughout pregnancy.
I felt I really rambled on this one. Like I should have structured it much better.
Yeah, I think if you find yourself in a situation where you're like, oh crap, that's a question that I haven't really thought about, or I've read about that but not for a long time, often common sense will get you half of the way there by saying, well, severe heart defects are probably quite bad for your health pregnancy, and you certainly bagged the why it's bad in pregnancy, and you could work back from that. Well, if the heart can't take high venous returns, what pathological cardiac states would struggle with that?
And I guess also what state the mother's in before. Like, is she walking up 100 flights of stairs? Then surely a pregnancy should be doable. Like,
absolutely. But if she's
like sitting down all day,
then a pickle is coming her way. So there is a guideline from the World Health Organization, and the chief ones where they recommend pregnancy is a bad idea, but doesn't mean that people don't get pregnant. Pulmonary arterial hypertension, severe ventricular dysfunction, so ejection fraction less than 30%, moderate systemic right ventricular dysfunction, and that's probably because of the venous return and risk of volume overload that comes with post-delivery uterine autotransfusion. There are two danger points, actually. There's the can you tolerate the physiological exertion of delivery, but then there is the contraction of the circulation and a spike that occurs in the first 24, 48 hours, a week or so post, where actually the heart then is even more burdened because you've lost that reduction in pulmonary peripheral vascular resistance because the placenta's gone. That was taking loads of the blood, keeping everything nice and low pressure. All that's gone. So then you've got now a newer, higher resistance system with still quite a lot of volume. So it's either at birth or just after birth where it all falls down.
You can see the scenario where the mother is going from having an organ extra to having one less organ, and the baby is sitting, and the baby is next to her, going from intrauterine to extrauterine life. It's like there's something to it.
Yeah, definitely. Fontan circulation with any sort of complication. So if you've got a perfectly spiffy Fontan circulation, you're still high risk and you need to be managed in an expert centre. But they'll say you can be pregnant, but let's be careful. Whereas a Fontan, it's not quite sparkling champagne, is bad for health. So now continuing on the same vein of cardiac risk stratification, you've been called to the postnatal ward. There is a lady and there is a baby. Unfortunately, this lady is exceptionally breathless with a respiratory rate of 30, a heart rate of 120, and she looks quite ashen and grey. What would your approach to this be?
So this is a medical emergency for sure. sure. I would declare it as such and call for help. So raise the alarm, so to speak. Without going into diagnosing her just yet, I would make sure she's breathing 100% oxygen. I'll make sure she has GCS 15, like is she obtunded or not. I would make sure she has 2 large IV accesses in which there should be fluids running. Is there blood on the floor? I'd want to speak to the to the midwife and talk about like how did this delivery play out? What is her history before this? So the ABC comes first, and then the history, and I guess we go from there.
Yeah. Okay. So you put oxygen on. You've established she's GCS 15 at the moment, but she looks pretty knackered. She is breathing quickly, and her blood gas suggests that she's got type 1 respiratory failure. So she's now got a PaO2 of 10 since she put 100% oxygen on. Her SATs are 97, 98 with that 100% oxygen. And you examine her chest, and you've got bilateral air entry with fine inspiratory crackles at the bases, and you feel her pulse. You're not really feeling a radial pulse. You cycle the blood pressure. It's 90/40. She's quite cold peripherally. What is going through your mind in terms of differentials for what could be happening right now?
So I have in my mind for this woman, I have 4 major differentials, and in the order of of likelihood, I guess, a major hemorrhage, postpartum major hemorrhage, is the most common one. Second to that, it sounds as if she might be suffering from a pulmonary embolism. For my third, I'll go for preeclamptic syndrome, which is less likely since apparently she was fine up until birth of her baby. And for the fourth, there's the dreaded amniotic fluid embolism. I guess that's similar to the pulmonary embolism. And I suppose she could be having a septic reaction as well, but the time course sort of makes me think that's not the case. This seems as if it came on very, very sudden.
Yeah. So amniotic fluid embolus. Tell me a bit more about that.
So amniotic fluid embolism is a syndrome of basically massive pulmonary embolization due to amniotic fluid entering the systemic circulation of the mother. Pathophysiologically, there are 2 theories to why this causes absolute cardiovascular demise, and it's the structural part of it, like the amniotic fluid obstructing the blood from the pulmonary artery into the lungs. And then there's an inflammatory theory around this, like the amniotic fluid is not supposed to be within the blood of the mother, and it causes an inflammatory reaction. It is a post-mortem diagnosis, and it's more of a likelihood diagnosis should the mother survive. The treatment is supportive. You need to support the circulation as well as the ventilation, and I do not believe there are any direct treatments other than supportive measures.
No, unfortunately not. No. So if we wind ourselves back 3 days in the past, and this patient's now has presented just like this during their labour and have unfortunately lost cardiac output, what would your approach be for a resuscitation scenario with a lady with loss of cardiac output during labour?
All right, so now we are in a ALS algorithm situation, and that calls for chest compression and intubation and ventilation as per the ALS algorithm. We proceed as usual through the algorithm with securing the airway, continuous compressions once the airway is secured, and every 2 minutes we reassess and give either adrenaline or we go down the path of shockable rhythms. The difference in the algorithm when it comes to this lady being pregnant is that the baby needs to come out, and I believe it's after the second defibrillation as per the guidelines. So they do it's what we call a perimortem cesarean section, and I believe this is top 3 do not want to live through scenarios. I'd rather not experience it.
Yeah. So you've mentioned early intubation because aspiration and they're challenging to ventilate with an IG when they've got a massive baby. You've mentioned perimortem section. There's a third chief modification that is easy to sort of misplace in your mind if you just
yeah. So there's one major physiological variable that you can correct very easily, and that is leftward tilt. Is it for the uterus not to compress the cable return to the heart?
Yeah, absolutely. And what's the purpose of a perimortem section in this situation?
I see it as if you want to restore systemic vascular resistance. Sort of, you want to minimize the amount of area for the blood to circulate on. Like basically the placenta and the baby comes out and you clamp those vessels, and you now have a circulatory system that is vastly smaller for the mother to have her circulating volume pass through.
Lovely. And what would be your sort of top differentials for cause of cardiac arrest in this situation?
So amniotic fluid embolus is absolutely one of those. If this was like during labor, the other ones would be eclamptic scenario. A regular pulmonary embolism could occur as well. And also, like the fourth one, I'd say would be like a primarily arrhythmogenic disease that has gone undetected. Like I still think that the most common cause for cardiac arrest in young pregnant women is undetected arrhythmogenic disease.
Yeah, like underlying undiagnosed cardiac badness.
Probably.
Yeah, cool. Okay, so that is physiology over. I'm guessing Swedish anaesthetists spend an obscene amount of time wading through labour ward.
We do. Placing epidurals is what we do during the night. Yeah.
Yeah. So
I'm actually transitioning to the pediatric side, so I'll be leaving that behind.
I'm so sad for you. It's like in the UK, it's a bit like Marmite. You either love it or you hate it, I suppose, isn't it? I like the science of pregnancy and pregnant anaesthesia, but I don't think I'm an obstetric anaesthetist. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging, and intermittent bashing through their 1100 plus questions, which they have written for the FRCA primary exam. Now, I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more, and they didn't really seem to reflect the content of the exams. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off, whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is, of course, GasGasGas. Cool. So trying to wind our way back through that, the way I might think about differentials in a cardiac arrest in an obstetric setting, you could either do it sort of trying to hang it off the 4 H's and 4 T's, but you might end up listing loads of stuff out. So I might be tempted to think about obstetric causes. That would be like your amniotic fluid embolus, your occult massive hemorrhage, placental abruption that no one spotted, and they've got DIC and just they've got nothing in their vasculature anymore. The medical stuff, like although technically peripartum cardiomyopathy is kind of obstetric, I'd put that medical alongside a pulmonary embolus. And then anaesthetic causes, anaesthetic whoopsie-daisies that lead to cardiac arrest. Oh, I've just topped up the epidural, but it's actually in the vein, and now they've got local anaesthetic toxicity, and we need intralipid. A high spinal that gets missed, or a very high epidural that gets missed, would probably be the ones that jump to my mind in terms of things anaesthetists can do that can cause bother.
That's incredibly slick. I would not have caught that mid-ALS algorithm.
Obviously, I've given you no history. If you're thinking, oh, their epidural was crap and we've been topping it up, and now she's had a cardiac arrest, it would lead your mind down that route. Perimortem section, it might be different in Sweden. The UK, they don't define it in terms of after how many cycles, I suppose you could argue. They just say the baby needs to be out in 4 to 5 minutes, basically. Because
I think it's 4 minutes, but you hang it on the cycles because it's easier to count, It's like
so I've been in this situation, and the bedlam that ensues means that time is just smashing forwards because you need to get a tube in because you can't ventilate them. CPR's happening, but they are 15 kilos heavier than they used to be with a massive baby in the way. You've now got a neonatal resus team, you've got obstetricians if they've come, and you've got your theatre team. So that time just piles away. So in my mind, after that experience, I would just say someone needs to be getting ready to take out the fetus from the off. Definitely in the exam, you would say, ALS guidance, we're going to do whatever the ALS guidelines say. But I think preparing and making that cognitive step in your mind early to prepare the team for what is coming when they're already terrified.
Yeah, it's sort of like if you say the baby needs to come out now, it certainly takes 4 minutes for you.
Absolutely. I had an obstetrician getting the baby out. They're professional baby extractors, and it took time because it's a moving target. They don't want to slash themselves. They've just got sterile gloves on, even though you could just do it in blue gloves or no gloves. Blood everywhere, sloshing around. It's just this really impossible situation. And yeah, you're right. The goal of extracting a baby isn't to save a baby's life, but often actually you do. It's to improve your venous return in the mother, reduce the burden of tissues to perfuse, to potentially get things going again, and you just pack the wound as best you can. And they're probably not going to bleed very much because they've not got a cardiac output. So yeah, messy, very messy. And then we sort of spoke about risk stratification of cardiac disease in pregnancy, and then the very start was thinking about the physiological changes of pregnancy, which is structured really nicely. And it's just like a classic question, isn't it? Because
I got hung up on the because I always do it from top to bottom, and I sort of got hung up on physiological changes to the central nervous system during pregnancy. Is there any hyper-excitability?
There is.
Hypo?
Yes. Yeah, so they actually need less anaesthetic. They hypothesize, although there's definitely no evidence, that progesterone makes the parturian require less anaesthetic. They're a bit more pliant. They'll just go along with it. And it's quoted that they need less anaesthetic, which is...
But then again, isn't the awareness reporting like tenfold?
Yeah, exactly. It's 1 in 500 or something like that. But where's that data from? How many of those awarenesses was actually in the UK? Ceftiroxime and thiopentol were the drugs that were used for antibiosis and induction. I wonder how many ladies got ceftiroxime inductions with suxamethonium once upon a time. Yeah.
And it's good.
People definitely used to. I think they much less do now, is they would be worried about delivering anaesthesia to the fetus that would lead to further fetal compromise. So they would fly very close to the wind along.
Our guidelines have actually changed, I believe, from not giving opioids to giving opioids, even during these hyperacute, or what you would call it, C-section.
In the UK, we call them like a category. Well, there's a category 1 cesarean section that actually can have a spinal, and then there's a true no time at all C to G compromise, bradycardia of 60, cord prolapse, general anaesthetic sort of category 1 cesarean section.
We just call them immediate.
Get on with it, yeah. And then the other thing is there's no faff time between the patient being anaesthetised and the surgeon jumping in. Whereas in a casual environment, especially in the UK with anaesthetic rooms, you anaesthetise the patient, there's some sevoflurane running, you drink your tea, and then you wheel them into theatre. There's greater time to achieve some CNS equilibrium that gives you a bit more of a chance of having them asleep enough. So yeah, despite the fact that you
said something interesting there. Like you said you put them to sleep, you turn on the SIBO, and then you wheel them into theatre.
So in the UK, we have anaesthetic rooms
with the whole anaesthetic machine, and you move everything into theatre afterwards
with all the kit. Yep.
Right.
Yeah. So we anaesthetise them. We've got ventilators, volatile, etc., in a nice anaesthetic room, and then you disconnect them from all the safety equipment, and then wheel them into theatre, and then reconnect them to another ventilator, re-establish a volatile concentration on the new ventilator with the new circuit, which is a risk point for awareness in the UK.
Surely that would contribute. That was my take on it, because we always do everything in the theatre room, like
yeah. But for obstetric anaesthesia, often people go to sleep in theatre because of the time. We don't want to be mucking around doing that. But for example, an appendicectomy case or some inguinal hernias, you'd do them in an anaesthetic room, and they'd have some time to cook, and then you take them into theatre. The surgeon's not even scrubbed yet, so then they're back on another ventilator, and then you're waiting, and then their blood pressure goes down. You're like, I just want the surgeon to get in there and do something to bring the blood pressure back up.
I don't want to be the one complaining, but you must have massive downtime.
Yeah, there is. Yeah.
For like the OR.
Yeah, it's really efficient. We can just do more work in the time, but don't listen up. I won't get started on that because we'll be here all day.
Maybe you don't have enough patience.
And the other CNS thing, although I think it's really low fry, is that the epidural space volume reduces. So less local anaesthetic will achieve a greater degree of blockade in an obstetric patient compared to a non-obstetric patient, is what they say. But, so those are.
I wonder how they got to that conclusion.
Yeah, I don't know. It's what I've got in this anaesthetic textbook. I've read it in a few other textbooks. But I suppose they do. We only give them like 0.125% bupivacaine up to 21 1 mils of that in an hour, but normally they get away with like 7 mils an hour of 0.125 and have sufficient block, not very much. Yeah, renal blood flow and GFR increase, creatinine goes down. So if someone has a normal creatinine in pregnancy, in late pregnancy, then actually there's probably something going on. Yeah, you've got the hemodilation of pregnancy and the hypercoagulable state, and we talked about the cable compression and your increase in cardiac output and respiratory. So yeah, you bagged all those things. There, you can say endocrine changes.
I just really don't want to go down that route, I think.
No, they might ask you.
I'm just going to open that door.
Yeah, they might ask you, so which one, is it T3 or T4 or both? So I think great structure for that. Yeah, I think that's fine. I have no issues there. Do you have quick reference handbooks in Sweden for like emergencies?
Yeah, we do. There's one circulating, which is the one everyone uses. The author is British. I know him in person. But yeah, we do have one of those.
Good stuff.
Would you reference that in an exam? Like, would you say I consult a quick reference handbook?
Yeah. So I absolutely would be like, declaring an emergency, this is clearly an issue. I'd like access to the quick reference handbook because it just demonstrates that you know that you probably do know everything you need to do, but it's better to run off a handbook. And actually sometimes for like malignant hypothermia, where there's like loads of stuff to do and it's a nightmare, and you've got to get like cooling from somewhere and charcoal filters from somewhere else, I would actually be tempted to hand it to like the nurse in charge of theatres and be like, right, we need to go through this guideline, call it out as it is, and delegate people to go and get stuff, so that you're not thinking, oh, where's the charcoal filters, when you need to focus on altering your anaesthetic to achieve some safety. So yeah,
these are low-hanging fruits for exam points, I guess.
It just demonstrates that you know that much like every other human on the planet, everyone might miss a useful thing or something that might just make your life a bit easier.
I think that's hard too, like in an oral exam, to sort of balance humility and insecurity.
Yeah, you want to come across as confident but safe, don't you? You don't want to just say, oh yeah, anaphylaxis, I just do these 3 things and it's all fine. But if you say, I'd get a quick reference handbook and then I'd go through it, then you might have gone too far the other way, and there's a balance there when you say, these are my priorities, but I want to make sure that I'm not going to miss something important or pertinent, so I want to use the handbook as well. So that was Martin having a dance with some physiology and quite a heavy interaction on obstetric anaesthesia. I remember in my primary FRCA Viva, I think 25% of the questions were pregnancy related. This is likely because in British practice, you quite early on in your career have quite a lot of responsibility on labour ward. So by their virtue of labouring the point, I think it perhaps corroborates and confirms safety to work with distance supervision. Boss at home on labour ward, when you're approaching that physiological changes of pregnancy question, which is a classic question, remember to break it down by system. Yeah, you can definitely start from head to toe or start from an A, B, C, D, E approach, remembering that parturient does have a difficult airway brought about by enlarged breast tissue, but also preeclamptic, so you can experience airway edema. Alongside those lower esophageal sphincter tension reductions and the higher gastric pressure of having a term baby in your abdomen, leading to a higher risk of reflux and aspiration. In the exam, you can certainly say MAC is decreased in pregnancy. However, there is an increased risk of awareness during a general anaesthetic emergency caesarean section. There are a number of factors that contribute to this. My practice to avoid this is, generally speaking, you don't want the surgeon just piling in, so you need to control the surgeon. Early high fraction sevoflurane may even be worth doing it whilst you are waiting for the rocuronium to work, just so that you're priming your anaesthetic circuit with sevoflurane. You can go down the route of further propofol boluses alongside your 1 milligram of alfentanil that I think is quite thoroughly recommended now to work synergistically with your propofol and reduce your odds of awareness. But you can use additional propofol boluses to maintain depth, remembering that their cardiac output is a fit, healthy person plus 50%. So have you done your cardioversion list in an 80-year-old where you give them 20 milligrams in weight and 20 milligrams in weight, and then they doze off and actually they're pretty flat for quite some time? A pregnant person at term is going to redistribute that propofol quite rapidly, so you need to keep that fraction up. Cardiac risk stratification, courtesy of the World Health Organization. This is probably more a final FRCA question than a primary FRCA question, so don't get too stressed up about that. Remembering the EDAIC probably falls between the 2 exams in the UK, but pregnancy is not recommended in pulmonary artery hypertension, anyone with severe ventricular dysfunction, i.e. ejection fractions less than 30%, or moderate right ventricular dysfunction. This is perhaps in part due to that volume overload issue that occurs with uterine autotransfusion perfusion post-delivery. That lovely contracted down uterus that was keeping your systemic vascular resistant free and easy is now driving your blood pressure up. Valvular issues, severe mitral stenosis, severe symptomatic aortic stenosis, a severe aortic dilatation, and vascular Ehlers-Danlos. Ehlers-Danlos, cohort of connective tissue diseases, but the vascular Ehlers-Danlos leads to blood vessels going kaboom, coarctation of the aorta if it's reoccurred, and any Fontan circulation with any complication. So if you've got a perfectly fine Fontan circulation, then it's okay. The other differentiator is where would you deliver these people? So WHO Class 1 and WHO Class 2 are deliver in local hospital patients, and these are mild patent ductus arteriosus, mild mitral valve prolapse, successfully repaired simple shunts like an ASD or a VSD, or in WHO Class 2, unrepaired ASD or VSDs, a repaired tetralogy of Fallot or Turner's syndrome without the aortic dilatation. Delivery in local hospital, keep an eye on them during their pregnancy. WHO Class 2 and 3 are alongside Class 4, which is the don't get pregnant class, remember. Delivery in an expert centre, so you'd think tertiary obstetrics with cardiology involvement. And this is everyone between the don't get pregnant and the follow-up in a local hospital only pregnancies. So I don't want to list everything because we're here all day. But those with mild ventricular impairment, those with mechanical valves, unrepaired cyanotic disease, severe asymptomatic aortic stenosis, moderate mitral stenosis, repaired coarctations. If they've got Marfan's, they just need expert follow-up, or if they've got an AVSD. So if you're in an exam and they're starting to ask you these questions, it's going to be quite a mess to list all this off. You can't truly be expected to remember all that. So you could open with, there's a WHO classification 1 through 5. Pregnancy is not recommended in patients with severe disease, severe heart failure, or pulmonary artery hypertension, vascular Ehlers-Danlos, or cyanotic congenital heart disease that's undergone correction that has a complication. Low-risk patients can be managed in a local hospital, whereas those with higher risk should be managed in a tertiary centre with close follow-up and care. Boom. Then if they ask you, you can say, oh, sorry, the detail is beyond me. Let's move on, please. Thanks very much. Okay, bye. Martin, organised, clear, composed, didn't jump to answering questions, thought about things before doing so. You're allowed a moment of silence, or you're allowed to say, well, I like to classify these things in, and hopefully by the time you've finished that sentence, you can start saying by pre, intro, post-op, by organ system, etc. So that's the second batch of Vivacast action from all these lucky folks doing Vivas this month. Martin still has 2 more to go, a clinical Viva and a physics and equipment Viva, but that's physiology for this week. Thank you very much for listening, guys. Hope you have a lovely weekend. Cheerio and goodbye. Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out GasGasGas.uk for the show notes, diagrams, details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.